All right, so our next talk is Radiation 101, SBRT, and its role in 2018. My pleasure to introduce Dr. Marc Gaudet. Marc is originally from Moncton, New Brunswick. Yay! He completed his medical school and residency training at Laval University in Quebec City, right here. He completed a master's in clinical epidemiology from Laval as well, and the Royal College of Family Physicians and Surgeons of Canada's Clinical Investigator Program. He then completed his clinical research fellowship at BCCA Vancouver, as well as a master's in health administration from the University of British Columbia. He served as a staff radiation oncologist, head of the radiation oncology, and director of oncology research at the Gatineau Hospital from 2013 to 2016, and then moved on to a position at the Ottawa Hospital in June 2016, where he specializes in gynae, head and neck, and GI malignancies. He is currently an assistant professor of radiation oncology at the University of Ottawa and a senior clinical investigator with the Clinical Epidemiology Program of the Ottawa Hospital Research Institute. He also currently serves as president of the Canadian Brachytherapy Group and medical examiner of complaints for the CISSS de l'Outaouais. His current research interests include inequalities in access to cancer care, which we can all relate to, co-effectiveness of cancer care, and brachytherapy. Welcome, Dr. Gaudet.
Okay, sorry, that was a bit long. So I'm a bit of a soft talker, so if you can't hear me, just let me know. So Dr. Cormier probably doesn't remember this, but I was actually a medical student with her probably about almost 20 years ago now, when I probably looked a wee bit younger and was probably a bit more enthusiastic. But anyway, so thanks for letting us lonely radiation oncologists come up here and give you a talk. So there are not only exciting things happening in the realm of chemotherapy, there's also really exciting things happening in the realm of radiation oncology. So big subject. So I have 45 minutes to talk to you about stereotactic radiation, which I could talk to you about for the whole day. So I've tried to kind of scrunch everything into one talk to get you kind of all the important things that you need to know. So and this is how I move forward. So I'd just like to say bienvenue à Québec. For everybody, I've spent about 10 years of my life here. I just went out for a run this morning and kind of on my old stomping grounds, looking at all the places we used to live right near here. So it's actually fantastic to be back in Quebec. So no disclosures related to what I'm going to present. There'll be lots of names of products. So there are about 2 vendors. So in radiation oncology, we essentially have 2 vendors that produce our products. So the names I'm going to be using are the same. They're commercial names. 2 companies produce them. So yes, I do treat patients with SBRT, mostly for liver, lung, and spine. So I can't say that I'm expert on every single subject that I'm going to touch upon, but many of them, hopefully I am. Yes, I did choose to be here, not because Lucille is scary. Yes, I am a French guy. I'll give you the top secret way to know that. So same as Dr. Carrier, if our name is Marc and it ends with a C, we're probably a French guy. And I am older than I look. So learning objectives. So again, you asked me kind of a big list of learning objectives there. So discuss the role of SBRT in curative settings, which is important. Discuss the role of SBRT in the palliative setting as well, and how it differs from standard radiotherapy. So radiotherapy has changed a lot, and I'll go over this. It's not just simple palliative radiation. Let's do a single fraction and send people on their way and not follow up with them. That's not what we do. So it's very important to see what SBRT is, when we want to fit that in, and what clinical scenarios, even people with metastatic cancer, when do we want to fit that in. So I'll provide an overview as well of the technical processes related to the delivery of SBRT, discuss patient eligibility, short and long-term side effects, and talk to you about drug interaction. So this is a point that was specifically asked that I found quite interesting, but there's unfortunately not much literature on that. So for those of you who know, I mean, you guys have been around hopefully as long as I have, radiotherapy has changed a huge amount, even from when I started training. And historically, there's many things that we were limited in doing with radiation, because if we could give everything 1,000 gray, we could cure anything, right? But we can't. And I mean, there's many reasons why we can't do that. So if we could give the tumor 1,000 gray, give everything next to it 0 gray, we'd be fantastic at what we do. But there's always proximity to vital organs, toxicity related to that, inability to concentrate dose for physical reasons, biophysical reasons, dose deposition, scatter energy, collimation, just limits that the machines have. Things like geometry, so you can't have a machine point it a certain way at somebody, and that can affect your ability to treat a tumor, right? So all of these things over the years have limited how we can deliver radiation in a very aggressive way. The other thing that causes problems, especially in some of the sites we'll talk about SBRT, is organ movement. So hitting a moving target for us is a very difficult thing to do. So this is just an example of how we've evolved, right? So when I started my practice, the image on the left there is pretty routine. So what we used to do is just take a pencil and draw out a shield on a film. So I mean, I've done that. And then you just say, after 44 gray, please stop hitting the spinal cord with dose. And that's what we did. And we were very good at doing that, right? But that's not a very good way of sparing things, because everything that was the open field would get through and through dose. And then we became much better with things like IMRT that came up through the years. And then we were much better at sparing things, and that allowed us to move forward. One of the other things that came about was stereotactic radiosurgery. So Dr. Lexell, who is a neurosurgeon in Sweden, developed this actually in the 1970s. So it's not a super revolutionary new idea of stereotactic radiation. So what they would do is they would put a frame on the person's head, or a stereotactic frame, and then treat brain tumors that way. Of course, with the limits of imaging back then, I mean, the target could only be so precise. But that is where the idea of stereotactic came from. And essentially the way I describe that to my patients is, if you want to describe how stereotactic radiation works, I always use an analogy of flashlights. It just kind of makes sense in my head. So if you're wanting to shine a single flashlight at one spot and say, I'm gonna have a whole bunch of light on that spot, the tract to get the light to that spot is gonna have a whole bunch of light on it, right? The way stereotactic radiation works, you can imagine it as kind of thousands and thousands of little tiny flashlights that are all meeting at the same spot. So you think about it, the deposition of light is going to happen right where all these little beams intersect. And that's the basic principle of stereotactic radiation. So instead of having one big, huge beam, we're having thousands of these little tiny beams that all intersect in one spot. So around that spot, and kind of that image on the right there, even though it dates back to the 70s, pretty much shows how that works. So by being able to do that and come in from many, many different beam angles, that allows us to be much more precise and give a much higher dose to a very small tumor. And essentially the way this apparatus works, which is called a gamma knife, which there's several of them throughout Canada, basically that kind of helmet that the person is wearing there actually has little cobalt sources in it that have binary collimation, so they either open or close and send a little tiny pencil beam into wherever the center of of the gamma knife is. So that's one of the ways that was initially thought to do stereotactic radiation, but obviously you can't put somebody's lung in a helmet, so that obviously couldn't work. So then we evolved to things like modern stereotactic radiosurgery that are frameless. So before we used to, and even when I was in Quebec City, not even 10 years ago, we used to have these stereotactic frames unfortunately screwed into people's skull, and we would treat them that way. And there's still places that routinely do that. We've very much moved away from that with much better immobilization and frameless techniques. So this is a newer, essentially a new gamma knife that looks very, very different from what it used to with frameless treatment. And that's how we eventually were able to move to SBRT. So what is SBRT? Basically, it's stereotactic radiation that's outside the brain, is basically what that means. And you're going to say, how do we define that, right? Because we're giving high doses to certain things. I give bone metastases every day, 8 gray in a single fraction. Is that stereotactic radiation? It's a high dose, but it's not very precise, so it's not stereotactic radiation. So we've defined it pretty much as, the CARO's definition is high dose radiation delivered in a fractionated way in a high dose per fraction. So anything above kind of 6 gray per fraction in a very precise way is considered stereotactic body radiation if it's outside the brain. And what has gotten us to there is improvements in machines, so improvements in dose delivery, improvements of motion management. So again, a lot of these things are moving targets. Tumors in the lung, tumor in the liver, people breathe, people move, soft tissue moves. So there's ways that we've improved our ability to deliver high dose to those moving targets, things like 4D CT. So you're saying, what's the fourth dimension? That is a very philosophical question, but the fourth dimension is time. So essentially what we do is we take a CT scan, but with time built into it. So multiple acquisitions at multiple different time points so that we can see how things move. And that allows us to be more precise. Things like tumor tracking. So certain of our machines, if we put markers in a tumor, it can actually follow the tumor as the person breathes, and then just treat when the tumor's in a certain position. Things like breathing control, so treating people only at a certain cycle of their respiratory cycle, or a certain point in their respiratory cycle is a way to control for that. There's also improvements in imaging, so things like when I used to be a resident, we used to sign off on daily treatment films that looked like a box with a little bit of gray, sometimes lines and things, and we say, yeah, that kind of looks like a pelvis, sure, they treated the pelvis. Which now we can actually do CT scans on our treatment units with what we call a cone beam CT. So that allows us every day set up the patient, take a low dose cone beam CT and actually see soft tissue definition and actually line up to that instead of just saying, well, the lung tumor's somewhere here between the ribs and the spine, let's treat there, we know it's in there. Very different nowadays with things like cone beam CT. Methods of delivery as well, there's newer machines, so this is not to say that one machine's better than the other. We can actually, so CyberKnife is one of the ways to do SBRT. There's only essentially 4 of them in Canada so far, but most stereotactic body radiotherapy can be delivered on a standard LINAC like anybody would have in any cancer center. There are, in Quebec, 13 cancer centers. I think 11 of them actually currently deliver SBRT, essentially on LINACs except in Montreal. So the other thing that we have to do is be able to immobilize our patients much better. There's also improvements like this. You can see it looks a bit scary, but it's essentially kind of like a giant vac lock, which is an apparatus with little styrofoam beads in it that we take the air out. It molds to the patient's shape. And there's also kind of this plastic thing that forms to the patient as well and keeps them in a set position while they're getting treatment. So it seems like a lot of investment, but when you're thinking about it, we're delivering the same dose we would have usually delivered in a 6 or 7 week treatment in about a 1 week treatment with stereotactic radiation. So to put all that time investment in getting them set up properly, so for example, when we treat a liver cancer patient with stereotactic radiation in Ottawa, they have a 2-hour treatment time. So let's say a breast cancer patient we bring in for a treatment is a 12-minute treatment time. So there's a lot more time investment spent in mobilization, setup, making sure they're exactly in the right position. That big black thing that you see, the big arch over there, is also an abdominal compression device to stop abdominal breathing, right? So that can also help with precision of the treatment. Again, different methods of motion control. You did see abdominal compression there, things like respiratory gating. So that's abdominal compression. Respiratory gating here is just so we can have little devices that actually detect where patients are in the respiratory cycle, and we can treat that way. So say only treat when they get to the peak of their inspiration, or treat within this certain window, and the machines can actually track that now, and the beam on will only come on when they're at a certain point in the respiratory cycle, and that's very important for treating lung with SBRT. Things like 4D CT allows us to, the other way we can compensate for motion if it doesn't move very much is what we call an ITV, or an internal target volume, which is essentially treating the area that we know that tumor can be at any time, which is what we call an ITV. And we do that with a 4D CT, and I'll show you an example of that later on as well. And the other way we used to do, which we do less and less except for liver, is put markers in things. So putting markers in a liver is relatively simple. Putting fiducials in prostate is relatively simple. Putting fiducials in a lung is not so simple. So we used to do that, lots of things like pneumothorax, and that was not super interesting to do. So that we've kind of moved away from, but it's one of the ways that we can track tumors as well. So this is what we call a 4D CT. So you can see here on, essentially on your left, just a single image on a kind of free breathing CT. The tumor can kind of be anywhere within multiple locations. And what you see on the right there are just 2 other examples of what we call a MIP, which is what we call maximum intensity projection. So it just means if you actually look at that circle, that's where the tumor can be at any time. So instead of saying we're going to treat that smaller volume, which we probably would have done before, we'll say, well, let's ensure that we treat that larger volume to make sure we're treating anywhere that that tumor can be at any time, right? Okay, I'm going to get to the indications in about 2 minutes. So the other thing, methods of image guidance, cone beam CT, you can see an example of how good a cone beam CT looks at the machine there. So the image on top is actually a CT diagnostic, or a planning CT. The one below is actually a cone beam CT that's done at a treatment unit. So they actually look pretty darn similar nowadays. The other thing the CyberKnife has is what we call synchrony tracking. So it actually has orthogonal, kind of diagonal X-ray units that the detector is actually in the floor there. You can see, and it will detect in 3 dimensions. Usually it'll detect either the spine or different bony structures or fiducial markers, and actually treat when those things are properly lined up. Okay, the last thing, and moving along, this is actually very exciting. So we're now moving to, us radiation oncologists are being kind of crazy with technology now. So we actually have an MR combined with a LINAC now. There's actually one that lives in Sunnybrook. So that will be kind of the ultimate image guidance modality. So you can do an MR live and then line up the patient with the MR and then treat on the same unit. So that is up and coming, very exciting. And Dr. Segal there from Sunnybrook that kind of led that part of things as well. There we go. So end result is treatment. So if I can get our AV guys to just click on that. So us radiation oncologists like to be super high tech, so I've actually got a video for you. So this is just an example of how SBRT works, right? So this is essentially a CyberKnife treatment for a lung cancer. And you can see what it does essentially is going to take orthogonal images. It will track the tumor, and you can see the machine actually, as the patient is moving with those RF emitters there as well that are fixed on the thorax. It detects the breathing cycle, and the machine actually, while the beam is on, will actually track the patient's breathing. So that allows us to be much, much more precise, and we can go back to the talk, much, much more precise with how we're treating those tumors. All right. So that should give you a good overview of, I don't know if that's okay, everybody's not confused yet with all my radiation jargon. So that gives you a good idea of how we do things. So a whole bunch of improvements in delivery, imaging, on-treatment imaging as well, and that allows us to do a whole bunch of things that we weren't able to do before. So where are we at in the curative realm? So where is this interesting? So for lung cancer, that is essentially one of the first places that we explored SBRT. And it's a problem that happens very often with people who have, let's say, a limited inspiratory volume or limited lung reserve, who can't get surgery for a lung cancer, but have a very small T1 and 0 lung cancer, but they can't have surgery because they don't have enough lung reserve. That's kind of where that started to be explored, kind of in the early 2000s, looking at, can we do that with radiation? So historically, we used to give these people 50 gray and 20 fractions, 60 and 30. So very long course treatment to people who are theoretically medically inoperable, so they're not super fit. And we'd be bringing them in for 6 weeks of treatment. Sometimes they're from outside. And the move, or the push, was to try to develop a method to do that in a very different way. And essentially, some of the first publications came out looking at 3 fractions. So we moved from 6 weeks of treatment to 3 fractions. And essentially, the thing with people with inoperable cancers is the local control is very, very good. So the risk of tumor recurrence at 5 years in that series was 7%. But if you look at the overall survival for people with very early stage lung cancer, it was about 40%. And most of them actually didn't die of their lung cancer. So these are people with very significant competing risks, so heart disease, all sorts of other things. But the local control was actually pretty good. So then we kind of pushed the envelope even more and said, well, can we move that to operable patients? And anytime we've tried to do this with surgeons, it's always a very tough sell to try to do a randomized radiation versus surgery trial. It sounds very exciting. And when you try to build it, there's always patient preference, surgeon preference, and of course surgeon preference always trumps everything else. I'm just kidding. But it's always a very difficult trial design to sell no surgery to someone, because everybody's going to say, well, just take it out. It's operable. Why don't you just take it out? And so essentially there were 2 attempts at trials for patients who were operable. And essentially, the overall survival is actually better, so not statistically, well, it actually was statistically significant, but it wasn't designed for that. So patients who had radiation actually did better. But again, very, very small numbers. You can only draw so many conclusions from that. And essentially the recurrence-free survival was the same. So we can say maybe 20 years from now, we won't be doing surgery in patients with small lung cancers, but we're not quite there yet. So if we look at NCCN guidelines and essentially what would be done in most centers in Canada, inoperable patients, so things like 60 and 30, 50 and 20 are a thing of the past. So we don't do that anymore unless there's a very specific reason to do that. So inoperable patients with very early lung cancers can be very readily treated with SBRT, and that in 2018 is routine practice. Same thing if they are operable but choose to. It's a rare scenario, but if they are operable and they choose not to have surgery, it's still a very valid option with very good local control rates. Toxicity is also very different from what we used to see. So for those of you who see lots of patients who get radiation for lung cancer, radiation pneumonitis with SBRT is actually pretty rare because it's a very conformal treatment, very limited high dose. And the low dose spray is actually not that significant. The things that we'll see more of is actually chest pain, especially if it's close to the chest wall. We'll also see rib fractures, which we didn't see that much of before. And as we moved along, we kind of figured out that that was one of the risks that came with that. And that'll be a recurrent theme when bones are close to the ears that get very high dose. Things like esophagitis, fistula, major bleeds have also come up. And this is where I put kind of a lesson learned thing. So when we explore things, initially SBRT had been applied kind of generally. And now what we've ultimately figured out is that patients with central tumors, which we've described as essentially on what we call the central bronchial tree, which is essentially about 2 centimeters from the main stem bronchus. If we treat those lesions with SBRT, they're at very high risk of having a major bleeding event or fistulization. So the fractionation scheme that was initially chosen in the beginning to give things like 60 and 3 or 48 and 4, we have very much moved away from for central tumors because some of these patients who are on the initial trials actually had very, very significant bleeding events and actually grade 5 toxicity, which is not very interesting. And so we've very much moved away from that. And the way around that is to change the fractionation. So usually people with central tumors like that will be treated to doses like 60 gray and 8 fractions, 48 and 8 different fractionation schemes like that. So just stretching out the fractionation a bit. And that actually is very effective with this toxicity of major bleeding or ulceration through the pulmonary artery or things like that, not being a concern with a lower dose. Okay, so liver SBRT, another moving target. So historically, treating liver with radiation was nonsense. So even when I trained, you would tell me, what do you know about treating liver with radiation? I said, meh, it's bad. And that would have been about it. And I would have passed my exams with that answer, right? Nowadays, it's not so simple. And the reason for that is that treating through and through the liver is very sensitive to radiation. So we can't give a very low dose to a high proportion of the liver. And that historically just precluded us from treating anything there. And HCC, as we moved along, this mostly was developed for HCC in the beginning. And HCC does have multiple treatment options. So, I mean, RFA is usually the favorite option for very, very small lesions. If we can't do RFA, we'll usually do TACE. And then there are some patients who we just couldn't do either or. So tumors that were not accessible by RFA, very posterior tumors, tumors close to the kidney, close to big blood vessels. Also tumors with quite significant portal vein thrombus we couldn't treat with usual modalities, so people started to explore SBRT in that setting. Most of the data have come in Canada from PMH, but with very good data in these patients. So this is a publication from Alexis Bugeaud, who's now in Montreal, but during his fellowship in PMH, looked at their series, and honestly the local control rates and the survival rates are comparable to TACE or RFA, and are even more favorable in patients with portal vein thrombus, who are patients who we essentially had no local therapy options for them before. So most of the referrals that we get are actually for patients with portal vein thrombus. With, again, local control rates in the range of kind of, I'd say, 70% in patients who, again, had really no other local options before. Their survival is honestly not very good, so these patients have a median survival often of about 2 years, mostly because of their underlying liver disease and their recurrence pattern, which they mostly recur in the form of multifocal HCC. Liver metastases, again, so those of you who've been around for quite a while know that we've had quite significant change in paradigms in how we manage liver metastases, especially in colorectal cancer. So we do have long-term survivors. So in our center, resection for a limited number of metastases is actually essentially standard of care. And I mean, there's fairly good data to justify that. The problem is that some patients will have a small number of metastases that are non-resectable. Let's say some, again, close to vital structures. Things like metastases in the caudate lobe will be very difficult to resect. So those are the kind of patients that we can treat with either RFA or SBRT, again, with very good local control rates in the range of 70%, again. And that increases with dose and with, again, with larger lesions, obviously our local control is not as good. So this is just an example of our process at TOH. So essentially, it's a very complex process to get patients to SBRT. This is the MR image on the bottom there is just one of my patients who we treat, actually 3 lesions. You can see 2 of them in the treatment there. So I usually tell patients it'll take them about a month to get there. So usually what we have to do is we have to place fiducial markers in the liver. Once that's done, we have to wait about a week for them to kind of set up shop in the liver. Once that's done, we do both an MR and a CT with the fiducial markers in place, which allows us to then plan the radiation. And the reason for the fiducial markers is they actually get gated treatment on the CyberKnife unit in Ottawa. So that allows us to take a much, much smaller safety margin around the lesions. And our usual fractionation is 3 fractions. So we usually give 54 gray in 3 fractions. Very large lesions we'll usually treat to 6 fractions, just to, again, kind of spread out the dose a little bit more, mostly for organs at risk, which are close to those. Liver SBRT is actually really well tolerated, to be honest. Things we'll notice the most is fatigue and nausea. Late liver dysfunction is actually pretty rare. Most people, it's actually related to deterioration of their cirrhosis, but kind of classic radiation-induced liver disease is actually pretty rare, to be honest. What we're most worried about is hollow organs, which are next to the liver, so stomach, duodenum. We have had a few patients with bleeds in Ottawa, and that's a well-documented toxicity of that. Bowel toxicity as well. What we see a lot of is if it's very close to the chest wall, to the diaphragm, they'll often complain of pain for, honestly, a few months after their stereotactic radiation, which we'll see. Sorry about that. If we move on to pancreas SBRT, sounds super exciting, so it's technically feasible. We can treat the pancreas with SBRT. There's been lots and lots of exploration with that, mostly in Europe. The problem with the pancreas is that it's close to everything, right? So it's close to the duodenum, close to the stomach, close to bowel, close to the CBD. So giving a really, really high dose of radiation that centrally in the abdomen is actually very difficult. And the toxicity we've seen is usually about 10 or 15% severe toxicity, mostly in the form of ulceration or GI bleeding. And this is just an example of one of my patients who was an elderly, I think 82-year-old woman with essentially a resectable pancreas cancer, but that didn't want to undergo a Whipple's procedure. And you can see just with the treatment field there, you can actually see the duodenum completely wrapping around the pancreas. So you're giving that a fairly high dose. The advantage of that is that we were able to put fiducial markers in her pancreas by EUS, and then have essentially a safety margin of about 1 millimeter around the pancreas. But there's still a fair bit of dose that goes to duodenum, which we have to kind of carve out of the field. She actually had quite a bit of mostly pain, but not frank ulceration, but not a frank bleed, but she did have quite a bit of pain after her treatment, which was quite surprising, and ultimately died of lung metastases and liver metastases. So that's the big problem with these patients. They can be locally controlled, but oftentimes they will develop metastatic disease, which again is the big problem in these patients. Okay, so almost to the end of the curative realm. So kidney SBRT is, again, an up-and-coming modality. So a lot of these patients will get RFA. So again, it's kind of the same logic as in the lung cancer realm. Patients who are medically inoperable have a small renal cell cancer that we're expecting to behave indolently. They can be treated very easily with SBRT. Historically, the same logic applied to the kidney. The kidney is very sensitive to radiation, so again, if you would have told me, can you treat a kidney cancer with radiation when I wrote my exams, I would have said absolutely not, and again would have passed, which nowadays is, again, not the same. So very, very high local control rates, but again, the series have very short follow-up. So that's an up-and-coming indication for stereotactic radiation. Prostate SBRT, so all of you that know me know that I'm a big proponent of brachytherapy. So one of the things about radiation techniques is there's a big differential between what we do in Canada and what's done in the US. And a lot of the data that we get is from the US. A lot of that is driven by funding and by who owns what machine. So if you drive down the highway, I went to Florida a couple of years ago, driving down the highway, said, come get your CyberKnife for your prostate cancer, when there was absolutely no evidence to support that. We are now getting to the point where there is much better data for prostate SBRT. The hopes of that in the US is that it can replace brachytherapy, because it's not complex, you don't need an OR, nobody's gonna bleed. So it's a lot less scary, and a urologist can buy a CyberKnife and just run it and make tons of money, which is what they want to do. Just kidding, but it's the reality in the US that honestly that brachytherapy utilization in the US has gone way, way down, because it's much simpler to just buy a stereotactic unit. And you tell patients, well, you'll come in for a week, just drive in from home, don't put you to sleep, nothing at all, nothing's gonna be poking at you, and you get 5 treatments and you're done. And essentially the numbers that we're getting out are actually very good. So biochemical control rates with SBRT, 5 fractions. Essentially all they need, they get fiducials placed in the prostate, they come in for an external treatment, 1 week, boom, everything's done. So it's very interesting. It's just the long-term data is not quite there yet. So what we're seeing in the data that's coming out is that the long-term data is probably not as good as the short-term data. So we're still kind of waiting for that before it becomes the norm. But there are a fair bit of patients in Ottawa even that are being treated with prostate SBRT. And I actually ran a study with one of our residents recently looking at cost effectiveness of these different modalities. And when you run it, SBRT would be the most cost-effective modality to use because it's very short. And the toxicity theoretically is about the same as the other treatments we use for prostate cancer. Okay, another kind of word of warning. In the US, they're applying stereotactic radiation to anything and everything, right? So even cervix cancer, I treat GYN cancers, and essentially when we look at SEER analyses, all the different analyses that have tried to take away brachytherapy from the treatment of cervix cancer, doesn't work. So essentially it's one of these worrisome trends where we're gonna say, well, we can give a big dose of radiation in a very small field with this new technique, let's just do that. And a lot of places in the US are not set up to do brachytherapy, so they're using these new units to say, we'll just replace the brachy with this, which is actually quite detrimental. So for cervix cancer, it is not the norm whatsoever, and should be very careful about that. And it's a very unfortunate kind of trend that we're seeing in many places, again, mostly in the US. Okay, so in the last little bit, SBRT for palliation. So the thing that's changing, and the reason why we've kind of moved forward with this, is that our patients are living a lot longer, right? So doing palliative treatment, especially for bone metastases, is a very different dynamic than it used to be, let's say 20 years ago. And so we know that radiation is very effective for pain control. That we know. So whatever fractionation we use, theoretically a single fraction should be standard of care. So 8 and 1, 20 and 5, 30 and 10, 40 and 15, 40 and 20, whatever number you want to throw out there should be essentially equivalent for pain control. What we know as well is that if we do a single fraction of radiation, the likelihood of us retreating is actually higher. There's actually conflicting evidence as far as pain relief with dose escalation. So we don't know that if we give a zillion gray to a bone metastases, that actually helps with pain. Because the underlying mechanism for pain control is mostly that it affects inflammatory mediators in the bone. It's not actually from tumor shrinkage that we're affecting pain, right? So that's why, in a certain sense, people would think that giving a big, huge dose of radiation to bone metastases makes sense. But the thing is that we're now in a different paradigm where you guys with chemo are doing a lot better, patients are living longer, and we're getting them second time around, a third time around, a fourth time around where they're coming back with pain in the same location, and then we're stuck. And you say, well, you know, I should have maybe given them a little bit more before because maybe it would have lasted longer. So we've now come into this realm of local control for bone metastases, right? Especially in patients with oligometastatic disease, patients with good prognosis. That has become the new focus. And a lot of talk in radiation conferences is more about local control in bone metastases than actually pain control. That being said, the data that we have for escalating dose with SBRT actually has essentially equivalent or better pain control than it does with standard fractionation. So it's not nonsense, it's just that we're moving to a different paradigm where we say, well, we don't want to retreat these patients, or we might not be able to at some point, and that's where SBRT comes in. So things like spinal metastases is one of the places where we've used that the most. And the objective of that is mostly to spare the spinal cord. So those of you who know radiation oncologists know that we lose sleep at night thinking about spinal cord doses. And the reasoning behind that is that at some point, if we have patients who are going to be around for quite a while, that is the thing that's going to stop us from being able to retreat them or to manage their bone metastases well with radiation. So this is just an example of one of my patients with a metastatic colon cancer, but a single site of bone metastases in his L-spine, causing quite significant pain, nerve root compression. And the thought process was, well, it's a radio-resistant tumor. He's responding really well to his chemo, but he's got this one site that's not doing well. Well, let's give him a very high dose of radiation, because the expectation would be to control that one site for a very long time. And that's actually what we're able to do with stereotactic radiation. The trade-off of that is that, so radiation myelitis was a thing of the past. So if we move back to, again, when I started training, you'd ask a radiation oncologist, have you ever seen somebody with spinal cord toxicity from radiotherapy? They would say, not really. I did see that in the 70s one day and whatever. But now with these kind of pushing the dose, there are now cases that we're seeing patients with spinal cord toxicity again. So it's kind of a word of warning that it's not a panacea. We have to be very careful about what we do. And we'll often get these patients back for retreatments with SBRT. So patients who've had 20 and 5 once, then they had 8 and 1 a second time, then you say, well, can you treat them again? And you say, well, yes, I can. We'll do it with SBRT. We'll spare the cord. The risk goes up. So it's feasible. It's just a question of knowing what the risk is and having that discussion with the patient. So SBRT fits, again, for bone mets, especially in the spine, in people with very limited bone disease, or people who are retreating is mostly where that fits in most centers. There's a few centers in Canada where they'll treat almost up front for spine metastases with SBRT, but I'd say that's not standard as of 2018. The other thing that we know about SBRT for spinal metastases is that it does come with a risk of vertebral fractures, and that risk varies from about 10 to 40% depending on where you look. Mostly in patients with osteolytic metastases, so some people shy away from treating things like myeloma with SBRT. Myeloma responds so well to radiation that honestly giving it a huge dose like 24 gray and 2 is not super useful, because you know it's going to respond to 20 and 5 or 8 and 1. So some people will shy away from treating those with SBRT. People with quite significant vertebral body involvement or instability, we'd probably want to shy away from. People who already have a pre-existing fracture, but that is not, honestly in our practice, is not a big game changer. People with lung or liver histology or things like myeloma, or the other thing you wouldn't want to do is do more than 20 gray in a single fraction. So some of the previous studies did things like 21 gray in a single fraction, which we don't do anymore, specifically for that reason. The other thing that's kind of emerging is non-spine bone metastases. So essentially SBRT has been applied mostly to spine because of the proximity to the cord, right? So the logistics of that makes sense, because you want to spare a critical structure that's stuck to what you're treating. SBRT just makes sense. There's a trial that's being run through CCTG by Arjun Sehgal at Sunnybrook, looking at 30 or 35 and 5, again with non-spine bone metastases, usually for patients with oligometastatic disease, again in this paradigm of local control, right? So that's what we're looking at now. Okay, so just quickly, new interesting things from CAGPO 2 weeks ago. I'll go through this first, because the other thing that's changing is this notion of oligometastatic disease, right? So this is just a head and neck conference I went to a couple years ago, that they were touting that we are curing patients with metastatic HPV-positive head and neck cancers. We are curing them of their distant metastases. That was kind of the headline from a study from PMH saying there are long-term survivors who've been treated for oligometastatic lung disease. So it then begs the question, should we be chasing after 1, 2, 3, 5 metastatic sites with very aggressive local treatment in thinking that this will help our patients? And that answer we didn't have till very long ago. So this is a trial run through David Palma's group in London. called a SABRE COMET trial. So us radiation oncologists also like having very nice acronyms. And this was looking at treating patients with either stereotactic radiation to 1 to 5 metastatic sites versus not. And looking at mostly progression-free survival and overall survival. And this was actually presented at CAGPO last week. And essentially, they almost had an overall survival benefit, a trial of just 100 patients. And it was actually a quite significant difference as well in progression-free survival in these patients, which you would expect would likely, it would also reflect time to chemotherapy, time to systemic treatment, and quality of life, right? 4 treatments that are honestly very well tolerated. So we're kind of moving to this new paradigm. This shift is probably going to happen in the next, I'd say, 2 or 3 years, where we'll get calls from our med-oncs hopefully saying, well, this guy has a single site in his lung and I don't know, a single site in his spine. Can you treat him with radiation? We'll wait a while and see if he gets chemo after. If those sites are controlled and can do a year without anything else progressing, then that might be an interesting paradigm shift in the next couple of years. Okay, so tolerance dose, the tough thing about treating things with SBRT, so this is actually the publication that we use the most, which is a Timmerman paper on dose constraints. So you know that us rad-oncs, thanks. So you know that us rad-oncs like dose constraints, right? We lose sleep over this all night. And it's interesting that the paper that we use as a reference actually says mostly unvalidated normal tissue constraints. So we're kind of feeling our way around in the dark with some of these things. The big scary things like spinal cord, we have very good data for. The other things mostly is a question of trying to extrapolate from previous data from fractionated radiation. And as time goes on, we're figuring out what these dose constraints are, but there's still quite a bit of uncertainty about where that falls. Things like liver treatment with doses to stomach, doses to duodenum, we're still trying to figure out. So we're very, very, very conservative about the amount of dose we're giving to certain things because of that. Because most of these things are, like I say, there's not that much evidence to back up the normal tissue constraints that we're using. And the toxicity of stereotactic radiation is the same as normal radiation in the same location. It's just that the risk is a bit higher because of that uncertainty, because of the high dose per fraction. Okay. This is the one I didn't like you guys for. So one of the specific learning objectives that I'll cover hopefully in about 5 minutes is what to do with SBRT and systemic treatments. So one of your specific learning objectives was what to do around timing of systemic treatments, when to stop them, when to start them. And I was kind of banging my head against the wall trying to figure this out. There's not much data out there on this subject, right? So it becomes more a notion of common sense. So what I've put up there is the notion of radiosensitization. So the same logic that we'd apply to normal chemotherapy. So somebody who's getting palliative radiotherapy to a single fraction, big dose per fraction, our notion has always been hold the chemo at least that day. So I mean, treating SBRT is the same logic, right? You're giving a big, huge dose per fraction. So anything that's going to be radiosensitizing, you're going to want to avoid. And the most radiosensitizing ones are things like gemcitabine, adriamycin, mitomycin C, which are things that mitomycin C, we don't give that often. But gemcitabine, you'll see a lot. And the platinum drugs are things that are going to be radiosensitizing, 5-FU. Those are all things that you're going to want to hold when they're getting SBRT. I think it just makes sense. We don't have very good data to support that. There's emerging data saying that it's probably safe to combine some of the chemotherapy drugs with SBRT, especially mostly for pancreas cancer. Things like gemcitabine have been combined with SBRT. But again, if we don't know it's safe, don't do it, is kind of the take-home message, and that's what we've always done. I essentially have no patients that get concurrent SBRT and chemo, so we just hold the chemo. And kind of the normal washout periods that we would usually keep, I'd say at least a week around, bookends around each, would probably be a safe approach. The other thing that's up and coming, all these new targeted agents, immunotherapy, what do we do with those in radiation? So if you would ask me the same question, you take out SBRT, you put fractionated radiation, same logic applies. We don't know. Because we've kind of got feeling around in the dark to know what that is. And there are a few that we've figured out have toxicity. Most of that actually comes from the stereotactic radiosurgery to the brain world. So things like bevacizumab, there are studies that show quite severe toxicity with SRS and a few with SBRT, which kind of makes sense with a gastric perforation with an abdominal SBRT. Very small studies, difficult to conclude anything, but again, word of caution, don't give bevacizumab at the same time as SBRT. Same thing with cetuximab. It is radiosensitizing. It's been used mostly in head and neck cancers. Quite significant severe toxicity, so same thing, not concurrent, and leave that washout period as well. Trastuzumab, Herceptin, probably safe. It's been used with brain stereotactic radiation safely. Essentially no evidence for SBRT, so we don't know. TKIs are kind of the same thing. Quite a few of them actually have some emerging data that they're not safe to be used concurrently, so we would stop them for that period of time. Be they Sutent, sorafenib, so all the EGFR TKIs, and there's a lot that have no other good convincing evidence for that. Immunotherapy is up and coming data, so the conclusion is it's probably going to be safe, but we don't know yet. So the same logic applies. I think with the immunotherapy, I mean, the mechanism of action and the timing of the action is different. So I think the best we can do is just make sure they don't get things concurrently. The effect of the immuno is still going to be happening when they're getting SBRT anyway. But I think the data that we have now is that that is probably safe. So we wouldn't be having a big, huge interval of stopping their immunotherapy before they get SBRT. But again, for us, it just makes sense not to have it absolutely concurrently in case there's a weird interaction between these medications and the radiation. Okay, so hopefully that was okay, but again, there's not much evidence out there to support what to do. So it's a question of discussing it with your radiation oncologist and us discussing it back with you as well about what the half-life of the medications are and what kind of different cautions that I put there are as well. So hopefully we covered our learning objectives well, and that's all I had for you. So hopefully some questions.
Everybody's stunned by all the techno stuff. Brave soul. You see.
Are you scared?
I don't know.
I was interested when you talked about that radiation was just given for pain control, not for disease control.
Right.
When you get to the third try with, one specific area, what is your expectation of pain control compared to the first time?
Right. So it's a question of how you do it as well. So sometimes you can wonder why they have pain is the first question, right? So if you've given them 2 rounds of radiation and it hasn't responded, people with things like a pathologic fracture, I mean, radiation is not extremely efficient to help with that. So let's say somebody's had 2 rounds of radiation to an area of their spine with a path fracture, mechanical pain, then you kind of take a step back and say, well, are they having pain because of that? Can we think about things like vertebroplasty? I mean, radiation is not the be-all, end-all of that. Sometimes it is a question of dose. So, I mean, people with GI cancers, people with kidney cancers, if there is, if there's not a fracture, but there's a certain mechanical effect or a certain effect from the inflammation or just a mass effect from a soft tissue tumor growing out, maybe the fact that we've given it a single fraction is not enough. And then, so this is where the paradigm is changing, that we know that people with radio-resistant histologies who might be around for a very long time, then we switch gears and we'll say first line we might do SBRT to the spine instead. So I was giving that example of a guy with a metastatic colon cancer with a single bone metastases. He might be around for a while still. So to give him 8 gray in 1 fraction is not going to be super helpful. It's not going to stop it from progressing. It's not going to stop a cord compression that he might get at some point. So those are the kind of patients where we're going to be in the next year shifting gears and saying up front we should be more aggressive with radiation. And the data that we're getting from, so there's a couple randomized trials coming out now looking at stereotactic radiation in a small number of sites. And the data is all going the same way, that we're actually improving those patients' quality of life, progression-free survival, and even maybe overall survival. So I mean, it's going to be interesting in the next couple of years to see that come out.
Mark?
So like with a vertebral problem, should you guys go first before they do a vertebroplasty, or who should go first?
Again, it depends. So the other thing that's coming out is post-op SBRT. So depending where you are in the world, people will believe that. So I mean, if you have a patient with a cord compression, then of course, like, if they're well, surgery is kind of the first consideration. If they have instability, so one of the things I put up there was what we call the SINS score. So you can actually run a score to see how unstable their spine would be. And if it's beyond a certain point, doing SBRT then becomes somewhat unsafe, because if you're going to make their bone even more unstable, then you want to think about surgery. So places like CHUM, and there's a few different places in Canada that are very aggressive with surgery. And the reasoning behind that is just that. So you want to avoid this person from having a complication from spinal instability. If you know they're going to be around for a while and there's that risk, do the surgery first, and then your objective becomes locally controlling that area. So they will do post-op SBRT to the area that was operated on. So that's another paradigm that's probably going to be, so surgeons are more and more open to treating our patients. It's always a hard sell to try to get them to do surgery, but if we can, it's quite a good option as well. And vertebroplasty, I mean, it depends on your view. So it's very much a question of what pain type they have. So it's very, very, very mechanical. In our center, we'll usually give them radiation up front anyway, in the objective that it will be controlling things to a certain extent when they go in for the vertebroplasty. There's also about a 3-month delay to get a vertebroplasty in Ottawa. But so the kind of paradigm we have is saying, well, we'll treat them with radiation, put the order in for the vertebroplasty. If they have absolutely no pain when they get to that point, then we'll just not do it. And if they get to the point where they're scheduled for the vertebroplasty and they're still in pain, then we do it at that point. But mostly for logistical reasons, which is silly, but it's the reality we have, yeah. Yep.
One last short question.
Hi, thanks for your talk. Yeah, I'll be very fast. I realize you don't work in pediatrics, but I was wondering if you had any insight as to immobilization in the pediatric population and also comforting that group when they need to be alone in the room.
Right. So pediatric population in SBRT is, not to say easy, but we essentially anesthetize them, which avoids all of those problems. The only thing that it complicates is positioning. So things like positioning them on their belly or something becomes very difficult. But other than that, I mean, and that again is up and coming. The reality with kids is that we're probably going to head more down the road of protons than SBRT. So there's much more data around protons than there actually is with this form of SBRT, because there's a lot more splay or low dose that can increase second cancers and things like that, which protons doesn't have. So if there are indications like that, a very small area to treat, oftentimes they'll be sent to Boston or to Seattle for that kind of thing more than that. But it's feasible in kids, and actually the anesthesia makes it a lot easier. Yeah. Thanks.
Thank you very much.
Thanks.